Yes.
Okay. All right, so platelet-rich plasma, anybody, when did you first hear about it? Besides the fact that I've been doing it? Anybody, do you remember, was it 5 years ago? Do you hear about 10
Years
years
ago,
ago?
I've heard about it.
Yeah. Anybody hear about like 10?
Brad's just gonna text
Yeah,
Justin
yeah.
and get back to you.
Yeah, 10 years ago? Did you hear about it? So it's actually started back in like about 70, 80 years ago, believe it or not. Okay, so it's not something that's been brand new. And anytime you talk about PRP or platelet-rich plasma, a lot of people roll their eyes going like, what is this voodoo, vampire kind of treatment? But it's been something we've been going on for like about 70, 80 years. So way, way, way back, it was used because people that with thrombocytopenia or low platelets, they thought, okay, well, we're gonna come up with this strategy where we're gonna have concentrated platelets, and then they used to transfuse people that have low platelets. Pretty good idea. And then, so that kind of worked for a while, especially in cardiac surgery where, they had to do a lot of transfusions. So they would use PRP in addition to transfusion that decreased the amount of transfusions that were needed. And then, so then people were looking into it a little bit more and then realized, gosh, it seems to do a lot of stuff. It's got growth factors and so forth. So, could we not use, this type of procedure to kind of enhance healing, right? So again, this is probably 60, 65 years ago, people with wound problems, so like ulcers and things like that with healing, they were injecting them into wounds and they were getting good results with healing. So it's like, oh, okay, well, it seems to be doing something there as well. So then it kept going on, people started finding different things to use for it. Okay, so we know that we're using it in orthopedics, but any ideas what else they've been using it for? Even like nowadays?
Skin and hair rejuvenation and
Okay.
hair regrowth.
Okay, so have you guys heard about that at all? Okay, so that's the so-called vampire treatments that they call it because they're using blood, right? And so that started with, well, actually even before that, the ENT surgeons and maxillofacial, they started using it because, they always have to use transplants to reconstruct things, right? And they're finding that in order to improve the reconstruction, transplantation they would use PRP and it seemed to work. And then the dental people, when they were putting their teeth back in, right, a lot of the problems with just adherence, they said, well, we can try this stuff as well. So if you talk to them about PRP, they've known about PRP way before us, and it's been working for them. So it's kind of a bit of a mystery as to why, we either seem to be really behind or don't realize it's something that actually has been working, that people are still reluctant to use because they just keep, I don't think, we have no evidence and so forth. Well, the evidence nowadays, we're talking about like a good 50 years of research, right? And I'm going to go through a few more things that have been more recent. In terms of the cosmetic stuff, so that became a huge thing, many, many years ago, looking at improving just textures and contours and softness of skin and so forth. So that became a huge thing, which is being used in just about every dermatology office nowadays. One of the things, if you don't believe in cosmetics and so forth, it's things like acne scars, things like that works really well as well. People with hair loss, it works. I think it seems to be more with people with, have these certain patterns where it's testosterone driven as opposed to genetics and so forth. So it seems to work on people that have more the testosterone issues and so forth. So, and I don't know too much about that type of research, but from the little that I do know, they use it a lot. I don't know what the results really are, but people seem to pay lots of money for it. So, and then, so then I remember like the first time I heard about it, it would have been probably, maybe almost 25 years ago, 25 years ago. And at that time I thought, well, this is like, there's no evidence of this. There's no way I'm gonna use it. It doesn't make any sense. I'm injecting people with stuff that potentially can do harm, and I didn't want to do that. And I think it was at a course somewhere in in California, and I was thinking, in fact, I was thinking I was doing PCL reconstructions or something. And during one of the breaks, talking to one of the reps who happened to be some track star down in the States, and she was telling me about how she had this Achilles tendonitis that just wouldn't go away. She had tried all kinds of things with, physio and ultrasound and blah, 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 and nothing seemed to work. And she got this injection, and it just made her feel better. And I still remember to this day, I left there and going, whatever, I mean, somebody, it's all in the head thing, right? And so then I didn't really think anything about it until probably a few years later, and there was a guy named Tony Miniacci, and Tony Miniacci used to work with all the sports teams out in Toronto. He was a bigwig. He ended up leaving, went down to the States and worked in Cleveland, and really, really like good guy, smart guy, well respected. And I found out he was doing this kind of stuff. But this, no one had even heard about this, no publications at all. And so I gave him a call, and I ended up, and I knew him well, so he was pretty patient with me, and I spent probably a good hour on the phone with him. And at the end, he just said, listen, Alex, I'm not going to convince you. Why don't you just try it and then see what happens? And I thought, I guess it's not unreasonable. I mean, and then the more that I learned about it, the more I realized, well, I'm not really injecting anything that's going to harm anybody. So why not try it? So this is like probably now, probably 15 years ago, maybe even a bit longer. So I enrolled 6 people, 6 people times 2, so 12 total. So 2 different kind of mini studies. And so they came in with the agreement, and we signed everything, consents and everything, saying that we're gonna do this procedure. I have no idea, what's gonna happen and whether I'm gonna have any good results or not. Risk, you're doing an injection, so just like any other drug, I guess you can get an infection or a local reaction, but besides that, I said, I don't think there's gonna be anything else that could happen. But remember, back then I had no idea about this stuff, right? So we did the first 6, and I remember, so it was huge with consent forms. We had all these questionnaires for them. Everything was kind of blinded, and the results for each of the 6 of them were just like, holy cow! They were like so happy, and they were asking, when can we do the next one? And I'm going, really? I mean, this is like voodoo. So then I did the next 6. Same thing happened. I'm going, there is something going on here that might actually be working. And so, but again, there's no studies out there, right? So nobody's publishing any of this stuff. And the few articles are more like, yeah, we've been doing these injections and they seem to work. People seem to be happy, but again, no science to it. Okay, so let's go to, so this is right after I did the study, and I was looking into these injections, and I was worried about whether or not it would cause issues. So, if you guys want to come over this, I can't really. No, I didn't do this pretty easily. Okay, so what we did, or what I did, was we ended up, because again, how do you do scientific studies? Because you can't, if you had any type of injection where you had miraculous improvement in cartilage, for instance, in the joint, then you might be able to see it on an x-ray, or could you see it on an MRI, or can you see it when you're scoping? But we're talking about really, really subtle potential improvements that you can't really see clinically on a x-ray or an MRI and so forth. And the patient would be telling me it's feeling good, but how do I scientifically prove it on a study? So one of the things we thought about was, well, could we then take the person's knee apart, take their cartilage out, and look at it and see if it's improved? Well, you're not going to do that because you're going to ruin the person's knee joint or whatever. So we thought, well, what about if I take the joints that I remove during a total knee? Because there's going to be healthy cartilage at some point around the knee joint. So we would take that and then take some of the arthritic knee portions of the joint, compare the two, apply PRP onto them, and see if it made a difference. Made sense. So what we did was we ended up taking these samples, and I don't know if anybody was involved at that time. You were maybe, I can't remember, because we used to be harvesting this thing, at the end of the case, and it was a big deal about doing like a proposal for this research thing. IH took forever to approve it. In the end, the impact that we had on patients was negligible because it didn't affect anything we did for the procedure itself. We just kind of spent like extra 10 minutes at the end of the case when the patient was being wheeled out. And so what we do is we take these samples, put them into a biological medium, and that way it would keep the cells and everything viable. Then from there, apply the PRP and see whether it made a difference. So initially, because I didn't know what we were doing, we just said, okay, what I'm gonna do is I'm gonna take the blood sample and I'm just gonna put it in and see what happens before we even try to isolate the platelet-rich plasma portion of it. So we did that, and if you look at okay, so control, which means the normal, and this is the one with cartilage that we put the blood stuff into. And lo and behold, what happened was, and this is kind of weird, so the superficial layer of the cartilage thinned out. Oh, that's not what we want, right? Chondrocyte density just means the cartilage density is the amount of cells. Okay, so if you compare that to the blood stuff we put in, it actually lowered density. It's like, whoa, what is going on here? I mean, we're causing cartilage that looks like it's less healthy. So then I realized, okay, well, that's good. So I know that we can't just be injecting blood into people. And that kind of made sense because, when you have a hemarthrosis from some type of trauma, you got blood in your knee, and you always worry about the blood that sits in the knee causing damage to the joint as well. And that's been shown as well. So it kind of made sense that this is happening. Okay, so great. So now what about just the platelet-rich portion of it? So now we're talking about taking just that portion of the blood, which I'll go over in a little bit later, but the reason why we centrifuge it was we want that one layer. So we did a second study, okay, and the second study was kind of the same idea. Okay, so what we did was, again, so we're looking at mostly, actually we did hips and knees, I think. Yeah, we did both hips and knees, but it was harder to kind of get the cartilage off the femoral head, so we were concentrating mostly on knees. Again, looking at the healthy portions and then the arthritic portions. Okay, so this is what we did. So you see how we would take a little plug out of the cartilage, so it kind of looks like that. It's got bone on the bottom and then the cartilage on the top part of things. So there were tiny little plugs that we would then place into like a little petri dish and then put all kinds of different biological mediums in there to keep it healthy. We ended up doing a short and long-term study. One was at 5 weeks and one was at 52 weeks. So that's how long we kind of left these things. And so this is just an example of, when we centrifuge it, you can see how the different layers. So we're taking just the kind of the top layer of things. Okay, and then what we did was then we would take each of these plugs at the end of the 5 weeks and the 52 weeks, we'd slice them up and then look at them under the microscope. And we're looking at different things so the cartilage has different layers. So if you look at cartilage, the soft part is this part, the bone part is this part, and then you've got different layers, which I'm not going to go into details, but the different layers have different cells, different structures and so forth. And each of the different layers have different biological reasons why they're there in terms of, either compressive force, tangential force for protection for your knee joint and so forth. And then the other things that are important would be, again, the cellular density, how healthy they are, and whether or not the cells would die off. So we ended up, okay, so this is kind of probably the summary of things. So if you look at using the different components, so just the platelet rich, the white cell rich, and the red cell rich components, we found that at 5 weeks, that superficial layer at 5 weeks and 52 weeks increased in thickness. Okay, so this is the first time we've ever been able to show anything from at least a pure scientific point of view that it actually had an actual biological effect. Okay, so here is an example. Okay, so again, if you look at this, 5 weeks, 5 weeks, control after the platelet stuff. Okay, I don't know if you guys can see that, but if you look at the transitional layer, it becomes thicker, and if you look at the chondrocytes, they also become denser. I know it's hard to see from there, but if you were interested later on, I can show it to you. And then same thing at 52 weeks, like a huge difference in terms of the thickness as well as the amount of chondrocytes that were in the cartilage. So it's like, okay, wait a minute. I mean, it looks like it seems to be doing something. So at that point, I was actually starting to get convinced that there was some merit to this. And so then we ended up starting clinical, like not just clinical trials, but actually offering it to people. So we ended up, I don't know, we probably did like maybe even 100 people by then at that point. And so at that time when we were doing it, we had people kind of call back. They had to fill up a questionnaire as to how they were feeling, whether or not it made a difference. And what we found was kind of the average in terms of efficacy of this stuff. It was anywhere from nothing, so some people had no improvement, to about 1.5 years. And the majority of them had some type of positive effect, and it went up to almost 1.5 years. So part of the way that I kind of try to be unbiased about this is that we never promoted it, I guess. So we did these 100 people, and then we left them, and it was up to them to decide if they felt that they wanted to come back to do it, if they felt it was something that was worthwhile. And so we were finding that people were calling us after 1.5 years, and saying, hey, can I do another one? Can I do another one? Without us actually asking them. So we actually knew that it was because they were wanting to have this stuff done. So it means that, there's got to be some type of effect. Again, I don't know if it's in their head or not, but for whatever reason, they were always asking to have this done. So nowadays, we, and some of the graphs and so forth, we're not going to go into the details, but if you look at, let's go back to, part of the reasons why it seems to be like this is working so well is because, again, there's been a lot more studies that have been done nowadays. And so it's being used now in just about every joint in the body, including the spine, tendons, ligaments, and so forth, for promoting healing. So people that have tendinitis, people that have tendon injuries, Achilles tendon and so forth, I mean, there's almost zero question anymore about those things. I mean, they work really well, and that's why even my own colleagues or so forth, I will refer them to me for those injections for those things. Okay, so that's fairly clear. In terms of promoting joint health and for helping joint pain, right? It's always still that, is it really working and so forth? I mean, part of the problem is that you've got to figure out, the subset of people that it works on, because if you have somebody that comes in with end-stage arthritis, nothing's going to work, right? So if you're putting PRP in those people, it's not going to make any difference. So then that skews your results, right? So somebody with mild OA, moderate OA, has lots of pain, they're not ready for a knee replacement, right? Cortisone is bad for you, as you know. You might have hyaluronate like Synvisc and Durolane that you can do injections with, but they're also limited in terms of what they can do as well. So those people, if you've got people that are not at a point where they are at end stage, but still have pain and want to improve, their pain levels, their activity level, that seems to make a big difference in terms of what you can do for them. So you've got to be very selective. So people are doing them in spines, they're doing epidural injections, doing facet injections. I started doing that just more of a favor for some people, but never really took off because it's not that easy, because we don't have the infrastructure here to do all of these things. and I do need, fluoro. I need to be able to have a way of guiding the needle into the right places and so forth, just like when we do the hips, but in the spine a little bit more tricky. So if you look at biomechanisms, again, I'm not going to go into too much detail, but there's studies now looking at why PRP works, because the amount of growth factors that get released from the PRP that help with enhancing both regeneration of tissue, repair of tissue, and improving, pain. I mean, it's from a biological standpoint, it makes a huge amount of sense. And then the other thing is just that the anti-inflammatory stuff as well, that when you put the stuff in, you know how you use anti-inflammatories, there's a mechanism as to why you suppress inflammation. Same thing happens with PRP. They've shown all these mechanisms that show that it works. So, great. So, I've got, in my mind, clinical trials that show that there's some improvement. I've got, in my mind, some good scientific evidence that I did myself that seems to support it. I never tell people that it's going to promote or improve your cartilage, even though the study shows that it might, but I never say that because you can't really show that or prove that. And if you start making people think that, oh, I can get a brand new knee by getting PRP, that's not what I want from people. I want people to say that it's something that can help me to get to a point where I can have a decent life until I need my knee replacement, because I'm either too young, too active, and so forth. That's what I want out of it. So above and beyond all that, then it came down to the protocol of how to achieve the best PRP mixture. And you know what it's like. I mean, there's so many different protocols out there, different ways of doing it. So we spent like crazy amount of time coming up with spin rates, duration, how we handle the blood and so forth. And in the end, because in the beginning we were making all kinds of mistakes. We were doing stuff and it was like, oh, this doesn't look very good, or it would clot, or it would do all kinds of stuff. And so after doing all these trials, and we're talking about just like months and months of this stuff, we came out with a protocol with the exact amount of time within X number of seconds, how quickly I got to start the spin rate, how quickly I have to administer it. And since then, we really haven't had any trouble at all. And I get notes and cards from patients like all the time going, just to let you know, I'm at 6 weeks, I'm at 3 months, I'm at 6 months, I'm at a year now, and I just can't believe what you've done for me. Again, it's not for everybody, but when people at this point still say, oh, this is still voodoo, and I still don't believe it, there's still no studies out there. Well, there are now. There's lots of stuff out there now. You just got to read it. You just got to be careful what you read, but from dermatology, from cosmetics to dentistry to orthopedics, it works. Okay, so in terms of when you guys practically come in to help me, okay, so let's talk a little bit about that. Okay, so most of you have just about everybody's done it with me, I think. No, not everybody. Okay, so the people that haven't done it with me, so I'm very particular in terms of how we do it. So when patients come in, I get everything ready because I have to have everything from start to getting the blood to actually administering it. I have to do it within 5 minutes, ideally within 4.5 minutes to 5 minutes. Don't ask me why, but it made a big difference in terms of the protocol. So when you take the blood out, okay, so what I want is to have this fill up as possible. I may not need the whole thing because the amount of PRP that we need, remember, it's quite concentrated, so it's not like, it's even though it's a small amount, there's a lot of platelet-rich plasma in there. When you take it out and you've got the blood, for some reason, and I don't even know why we did this, but we tried where we mixed the blood and tried to isolate it, and for some reason it made it clot more. I don't know why. So we have to be careful handling it. So as soon as you give it to me, don't handle it, don't mix it, just carefully give it to me. And then when we put it in here, what you want to remember, that's happened to me before, it's always a balance thing, right? So when this thing spins, if you don't have a balanced one, with one on the opposite side, then things are going to start to wiggle and wobble and so forth, and you don't want that because it'll wreck the machine. And then, so I take it, I put it in there, and then I have all the settings here, so it tells you about spin rates and duration, okay? So We used to have an older model that we were using, but we found that it didn't give me the spin speed that I wanted, and that's why we got this one. And so I set it. It doesn't matter. You guys don't need to worry about that. It's my job to make sure. And what I found was amazing, because if I moved it from here to here or here, because we did different steps, it made a huge difference in terms of, again, the quantity, the quality, and the clotting as well. And then the duration, so you'll see me as soon as it goes in there, I got my phone and I put in the time. And then you'll see that, like, I'm watching, and as soon as it hits a certain amount of time, which for whatever reason it's 4 minutes and 25 seconds, I don't know why. Again, it's crazy, the difference. So then right away I gotta take it out. Whatever joint that I'm doing has to be all pre-prepped, so I'm ready to go, because I can't wait, because once I dig the stuff out, it's gotta get in there immediately. And I think that there were studies that were done, again, this is like decades ago, looking at, you know, the viability of the platelets and whether or not they were able to keep them healthy to be able to use for transfusions and so forth. Well, they found that it didn't take very much a long time for it to die off. So what they were doing was they were cooling it down to like 4 degrees and putting them in the fridge to kind of maintain it. They had to use it within 24 hours and so forth. Well, yeah, it kind of made sense to kind of keep it healthy, but for us, we want to keep it as fresh as possible so that it has the most bang for our buck, the best growth factors, and that's why I don't want it to be exposed at all. I want to get into the joint or whatever tissue right away. So everything's pre-prepped, we're ready to go. I take the stuff out, I have it in my syringe, because everything's ready, then boom. If I'm having floral, because that's the biggest thing, I have to make sure the tech is there, they've already isolated the joint, they've got the floral machine ready to go, so that right away I can guide my needle into the joint. So for you guys, I think the biggest thing is, you know, when, again, it's not rocket science now, because it seems like it's like really simplistic, but remember, a lot of work went into kind of coming up with this. But to make sure that if I need x-ray, the techs are there, the floral machine's working, and we've already did that little trial to make sure that it's got the joint on the machine. Number 2 is to make sure that when the patient is getting the blood, that when you're doing it, no mixing, you give it to me right away, and then to make sure that the patient is ready to have the injection, whether or not they're lying down or sitting down. For me, ideally, I prefer sitting, okay, for the knees, okay, and the reason for that is, and then people go, well, that's crazy, because then what if they feel lightheaded and so forth? Yeah, it's possible, so we do have to be a little bit careful, but the reason I like that is because when they're sitting down and their legs on something, they're not, if they flinch, it doesn't move it very much, okay, so, but if you're just lying there on a table, it's easy to kind of kick out, and I don't want those things to happen. So in that position, you also have the joint at the maximum amount of opening, so there's a bigger joint space. And you've got to remember, people with arthritis, their joint space is already narrowed, so you want to make sure that you want to maximize the benefit of being able to open up that space. I always have in my head, prior to doing the injections, I know where the OA is. So if it's mostly on the medial side, which is 90% of patients, then I will go lateral, because there's going to be more joint space there. If it's the opposite, where there's mostly lateral OA, then I'll go medial, because there's more of a joint space. For hips, you always have to lie down, because we have to guide it through floral. For tendons and so forth, depending on the tendons, so if it's Achilles, they're prone. If they're elbows, then they can just lie there with their arms like that. I don't do very many shoulders, but shoulders I tend to do sitting up, and then spine's obviously in a prone position. Afterwards, okay, so there's protocols vary. So we did, in the beginning, tell people, okay, you can't do anything for the next 3 days or whatever. You can't use anti-inflammatories, you can't use turmeric, you can't use, so all these things. And then after a while, then we started kind of pushing that back a little bit, because it didn't seem to make a difference if they were using their medication. And then said, oh, okay, we'll try 2 days. Okay, we'll try 1 day. So now what I tell people is just that for the first day, keep calm, you can walk and so forth, but no exercises. And the next day you kind of get back doing things. I'm still not convinced whether or not that's really, you know, important, but I think if nothing else, it kind of keeps the patient aware of the joint that they had. And if there is an increased amount of pain, warmth, redness, and so forth, then to contact me, and then
let me know. If they're already doing exercises and, sweating and so forth, sometimes you don't know if it's from their exercise, it's causing pain, so I think that's part of the reason why I'm doing it. So when I meet somebody, I go, okay, so this is what we do. You come in, you get your injection. The injection risk is exceptionally low because it's your own platelets, so you shouldn't get there's no reason why you would get a reaction. The only thing would be, you get an infection from the needle for whatever reason. You shouldn't even get a site reaction because, again, we're not putting anything foreign in there. So then they go, well, great, that sounds really good, but what about comparing that with cortisone? What about comparing that with Synvisc and Durolane and all the other hyaluronate injections that we have? So if you look at cortisone is a great injection modality for people that have acute injuries or acute flare-ups, because it's like having a bad headache, so you take your aspirin or your Tylenol and it helps it go away, but in the long term, it's not going to do anything. So if you come in and you're just like miserable for a couple weeks or whatever and you can't move around, yeah, not a bad idea. But you can't sustain that joint with cortisone because eventually having too many of those injections will actually inadvertently cause more damage to the joint cartilage, so you don't want that. Hyaluronate, which is that Synvisc, Durolane stuff, so that stuff, you can get a reaction to it because it's foreign, right, material. So I do warn people about that. I find that I was probably one of the very first people to use it in Canada. So we used to use it in some of my athletes back in the CFL. And I remember way back when we started using it, I mean, we had no idea what we were doing. I mean, again, we're injecting these things, and I am sure I would inject wrong into somebody's joint and maybe hit something or whatever. And then they would get a reaction, and I'm thinking, I've ruined this guy's career, right? So, I would admit these guys after an injection, and we do all these blood tests and thinking I got an immune reaction and so forth. And now, I mean, having many years of experience, I just realized it's just a reaction because you're putting it into tissue and you're probably forcing it into tissue as opposed into the joint space. So the reaction, it's pretty rare nowadays if you do it correctly. But I do warn people that you can get that. You can get an allergic reaction because, again, it's foreign. The hyaluronate stuff tends to be 50-50 in terms of improvement for people. So you either get a good reaction and it seems to do well, or nothing happens. And the average time for that stuff to kind of be effective is about 3 to 6 months is what I'm finding. I know that a lot of the companies probably think it's longer, but that's probably what my experience is. I do have people still, not that many, but a few that find that it actually does last a year and they come back every year to get them. So I said, yeah, it's working, I'm gonna keep doing it for you. So when I compare that, so there's been studies looking at cortisone, looking at hyaluronate, looking at PRP, and the graph is pretty straightforward. I mean, PRP lasts way longer and the effectiveness seems to be a lot better. So, but I always give people the option because I don't have any bias, because I don't care, you can do whatever you want. I mean, I'll help you with it, whatever you like. But I give them all that information. And then afterwards, as they leave, okay, then again, I tell them the same thing. Look for increased pain, redness, swelling, and if you're not feeling well, temperature, anything like that, let me know. I've been doing this for, I don't know how many years now. I've never had anybody have a reaction to it, ever. I've had one person in all my times where I could not do the injection for whatever reason, despite the protocol. I could not get a good sample from the blood, and we went back to look at her history and couldn't figure out why. There was no reason for it. We actually did have cohorts of people that were taking anti-inflammatories, smokers, people that were on certain medications, people with like apixaban or Coumadin, people that had thrombocytopenia. So we did all of these studies looking to see whether it made any difference, and we couldn't find any difference with any of these people. And I don't know what was wrong with her, but she was the one person I just could not do. All right, talked a little bit too much here. So anybody have any questions, or does that make sense?
I think we should not draw the blood too early for you because sometimes the blood is clot.
Yeah. So we kind of time it a little bit because you can start a little bit ahead of time because it doesn't take me that long to get everything ready. But never do it like, oh, I'm getting the blood ready already and I haven't got time to prepare, because once it hits that 4.5 minutes mark, I can't use it. Yeah.
And you don't use preservative in your tube, right? It's-
So that's interesting. So I used to,
Yeah,
and we found that the reason why the preservative was there because it helped to stabilize things, and so then we started trying to do it so it's all natural without the preservative, and that's where I think the timing stuff came in, and we found that it ended up being similar. So I think the preservative is still a good idea if you if you want to have more time, I guess, to do it and so forth. We don't. We that's why we go and get it done. That all makes sense? You ready to do it with me? Awesome. Great.